Thank you, Andrea. You introduced the newborn screening for Pompe concept very nicely. So I am Deeksha, and I'll take you along that after the newborn screening comes positive, how we go along when we get the sample in the lab from Missouri majorly. But now we are starting to get samples from Illinois and New York and Texas, because they do have a program to confirm it, but still the level of confidence comes with experience. So these are a few disclosures. Sorry. So as Dr. Wilcox said, that in Pompe disease, sorry. So the idea is to the whole idea of newborn screening is to catch patients at the very, very early on, before the symptoms develop or where the symptoms are in late onset Pompe, so that there is no damage to the muscle or very limited damage, and it can be reversed. Once the damage is gone to the point where there is point of no return, then even the enzyme replacement therapy does not reverse the process, but it stabilizes the disease. So Pompe diagnosis, even now in the newborn screening era, the clinical symptoms, as Andrea said, that the patient has to be brought back, the clinical symptoms, infantile versus late onset, that is the key to get started. And then you need to have a definitive biochemical diagnosis showing enzyme deficiency, and of course DNA analysis showing 2 pathogenic mutations. Once you have all these three things working together, you have a concrete diagnosis of Pompe, and you know that you have a baby with Pompe. And in our lab, we developed this dry blood spot-based testing method back in 2006. And we just used our lab controls at that time, but later on when newborn screening for Pompe was coming into being, we tried newborn screening spots, and we can clearly separate affected patients from the normal newborns or the other lab controls. So we are still using this method. And we measure GA enzyme activity in dry blood spots. And some labs, they use purified lymphocytes or leukocyte assays. They work good in those hands too. And very rarely, we do need skin fibroblast cells to measure the residual enzyme activity, especially in the late onset Pompe scenarios. Many physicians want to know that what is the residual enzyme activity, so that they want to know when is the disease process going to start. So then the parents keep coming to them. They do have skin biopsies. And then skin fibroblasts can also be used for CRIM status determination, where it is not possible to do CRIM analysis, predict CRIM analysis from mutations. And as many labs have established already, that the peripheral blood, it is a very rapid, reliable, and sensitive method to diagnose both infantile and late onset Pompe. And in our lab, our turnaround is less than 48 hours from the time we receive the sample. And within 4 to 5 days of receiving the sample in labs, we do have mutation analysis completed. And with any blood assay, it is very, very important to use the to block the isozyme, which is maltase glucoamylase, with the inhibitor. Otherwise, you can measure neutral maltase activity, and that will give you false negative. Or if you use too much inhibitor, it will give you false positive results. So in our lab, besides using the GA enzyme assay and also the pathogenic mutation, we also take the help of the urinary hex4 assay, which is a very simple assay. We can do it on urinary spots or a frozen urine sample, and that has actually helped us weed out the infantile onset classic phenotype from the non-classic phenotype or late onset within like 24 to 48 hours, because this is a quick mass spec based assay. So the way we go about it is positive screen. It comes from the newborn screening lab. We receive a blood spot, sometimes along with the whole blood sample. We do the confirmatory testing, and if GA enzyme activity is deficient, if it is not deficient, then it's not Pompe. That is where it stops. We do not pursue gene sequencing if GA enzyme activity is not normal in our hands. But if enzyme activity is deficient, then of course immediately gene sequencing is done if 2 pathogenic mutations are identified, very good, we have a diagnosis. And we can actually predict 92% of the times the CRIM status on the baby based on the mutations. And point to make here is that diagnosis can be missed if the infant has had a blood transfusion already. By the time we get sample, if baby was very sick and baby has had a transfusion already, you can miss a diagnosis. And I get many calls, you cannot determine residual enzyme activity based on this assay. It just tells you affected or not affected. You cannot determine residual enzyme activity. So based on our lab data, from infantile onset Pompe, 8 patients which we have got, our activity ranges are 0.2 to 2.6, and this is of course dependent on the mutation, what is the mutation. And in late onset, again, there is overlap of activity. So that is the reason you cannot tell infantile versus late onset based on this assay. And then carriers of one mutation, with known one mutation, there are some of the mutations are reducing the activity level where they can be very close to this thing. And so again, you cannot rely just on enzyme activity. You have to have mutation to tell that this patient is a carrier. And then the new, the million-dollar question is pseudodeficiency alleles, which we are seeing with or without one mutation. If it is without one mutation, then activity tends to be a little higher. But if it has in combination with a one mutation, it is very, very hard sometimes to weed them out. So this is what we see usually. This is infantile Pompe, atypical infantile Pompe. This is late onset Pompe, and this is our cutoff. And carriers or pseudodeficiencies, they tend to scatter somewhere here. But when you combine this with one mutation, sometimes it is very close to this cutoff line. And then mutations, these are the most common mutations we have come across. This is common African American mutations. Once we see this mutation, we know it is going to be a CRIM negative baby if it is in homozygosity. Once we see this mutation, this is a Dutch mutation, we know this is going to be a CRIM negative baby, and the ball starts rolling for the ITI protocol. This is, of course, late onset mutation, and to our surprise, this is label is late onset mutation, but we are seeing this a lot in the newborn screening scenario. I think we have 8 cases through newborn screening who are homozygous for this mutation. So this is like non-infantile late onset mutation in newborn screening scenarios. And this exon 18 deletion, it's a complicated mutations. One needs to design primers specific to not to miss this mutation. So this usually results in CRIM positive status. If there is exon 18 deletion mutation, you know it is going to be CRIM positive. And besides this, where we can only pick up one mutation, they go for deletion duplication analysis. And there are large promoter region mutations or intronic mutations and or large exonic deletion, which are rare and family-based mutations. So coming to this, as I said, we have 8 patients now which are homozygous through the newborn screening for this common mutation, late onset mutation, but these are through newborn screening. So this patient population is very, very important to follow very closely to see when the real symptoms will develop, because we name it as late onset Pompe mutation, but we don't know in homozygosity when the symptoms will actually develop, that these are the babies who should be caught early and started treatment very early before the damage is done. And this mutation, if you don't design primer which go beyond into the little bit into the promoter region, lab can miss this mutation, and there have been instances where this mutation has been missed. And then pseudodeficiency alleles, as Andrea said, there are a lot of individuals with the pseudodeficiency alleles, and when it started originally, the papers came out from Japan and from Southeast Asia that if these alleles are present in cis, they reduce the enzyme activity in vitro enzyme testing systems, but these individuals, they are present, 4% of normal population has these alleles, and they do not express disease. So that is why they are called pseudodeficiency alleles. But what we are seeing in our population is they are not necessarily in cis. They could be in trans. So if they are in trans with one mutation, what do we call them? Pseudodeficiency alleles, and what do we do with these patients? So these patients, again, for all the newborn screening programs, they should not fall through the crack. They need to be followed up to see how, and we have seen some of these pseudodeficiency alleles in patients from Caucasian patients, and also from Indian population and from South American population too. So it is everywhere. And so the long-term follow-up studies based on population is very, very important to learn from these rare cases. And very briefly, I'll touch on the Western blot. Why do we determine CRIM, and why do we do Western blot? So traditionally, Western blot, what we do to determine CRIM status, we use skin fibroblast. That's the gold standard. It's a standard Western blot analysis on the protein. You probe it with anti-GA antibody. And then GA, it is a very complex protein. It's in the sense that it presents itself as 110 kilodalton, which is unprocessed precursor protein, inactive. It goes through 95 kilodalton, again, intermediate form, inactive. The only active form is 76 and 70 kilodalton. So that is what we do. But now, this is how the gel looks. This is CRIM positive, and this is CRIM negative, no band, CRIM positive, weak band, and CRIM negative. This is how do we see it, and this is on skin fibroblast cells. So now we are trying to develop a method for blood CRIM analysis using blood sample. And for this, you need a specific tube, which is a CPT, sodium citrate tube, which we actually send. It is an expensive tube in the sense it is $9 or $8 a tube. So not every hospital, lab, or clinic, they have it. So we ship the tube to them. They draw the blood. We isolate PBMCs. We run the gel. And we can tell individual will be CRIM positive or not. This is CRIM positive. This is negative. And this is the beta-actin control. So this is, it's not a clinically available assay yet, but hopefully if we have enough data. But we are very comfortable calling CRIM status based on the mutations we are finding. Based on our experience so far, all the deleterious mutations, which are nonsense, frame shift, splice site mutation, which is a little difficult to predict, large deletion, initiator codon, they are all CRIM negative. So what we have done, we worked, okay, I'll go. So GA gene is very, very highly polymorphic. Every individual has new variant, and these variants are unsighted. So no matter how many in silico models you use, polyphen, SIFT, mutation taster, tester, whatever, but at the end, these are just tools. They are not 100%. You need a functional assay, and the only functional assay so far available is proving that this variant causes enzyme deficiency. And the familiarization with the GA gene is very, very important, because these common mutations and common polymorphisms, where they exist, what they do, how they form a haplotype. This is a very important information for any lab who is delving into newborn screening. So we work with our IRB and convince them that this is a kind of public service work we want to do. So they finally, after working with them and after working with Duke Legal, 18 months it took us, an 8-page long disclaimer now. So on our website, we have put on mutations, which is about from 200 patients, mutation data, CRIM negative and positive. We have put on our website, and it is very nicely listed with each exon, cDNA change, amino acid change, and the references wherever it was published. So hopefully this tool will be very useful for any newborn screening labs as they start newborn screening and to see what these mutations are doing. And as I touched very briefly, I won't talk much. This is the urinary GLUC4 or HEX4, which we use as a biomarker. This is a breakdown product of glycogen. So it's not specific to Pompe, but in Pompe it has helped us a lot. So this is from Taiwanese newborn screening data, They collected baseline urine samples. At the end, they send us all the samples, and we analyze them. And these were blinded to us. Very nicely, you can see that infantile onset Pompe, this is the cutoff for HEX4. They were here. These are late onset Pompe, and these are late onset, which they have not treated yet. These have been treated, they have not been treated, and these are carriers and pseudodeficiencies. So this really showed us, and this just got published, that HEX4 is a really good tool. And then we try to look at from the Missouri data. This is enzymology data, which I just showed, and this is HEX4 data. All the 4 infantile onset Pompe, they are here. This is atypical infantile Pompe who do not have a disease yet, and these are late onset Pompe. So HEX4 is a very good tool to weed out infantile Pompe who need to be treated right away. And I think Missouri people, they get very happy when they get to know that the HEX4 levels are within normal limit. So in conclusion, urinary HEX4 is very useful, and it can really help you identify infantile onset Pompe and weed out the late onset from the pseudodeficiencies. And the cases of VUS or single mutation, they need additional tools for confirmatory testing. You can use additional tissue testing like skin fibroblast, and deletion duplication analysis needs to be done. And sometimes we have come across where the individual have mutation through the next generation sequences, they have mutation in another myopathy gene. So if they are heterozygous for this, they could be heterozygous for another myopathy gene. So those individuals could develop some symptoms which will mimic Pompe. So parental testing might be needed to resolve rare complicated cases. So it becomes consenting process will come into play there. And I will end with this, thanking all the patients and their families. We could not have learned about Pompe without their participation in this whole team and teaming with us. And this is the Duke team working together, and Missouri team. We, I think, correspond every day, 10 times a day. And now New York and Illinois. Thank you very much, everyone.